By Dr. Riyad Salem, who's here visiting us from Chicago. He's a director of the Interventional Radiology Program at the Lurie Cancer Center, and he's going to tell us a little bit about ongoing clinical trials of radioembolization in neuroendocrine tumors.
Thank you. Thank you for the introduction. It's really a pleasure to be here. It's an honor to have been invited for this presentation. Today and this afternoon, I'll just be discussing sort of the clinical trials that we have ongoing with radioembolization in neuroendocrine tumors. They certainly can't compete with what you've seen over the last few presentations, but I hope to entice enough people to maybe get this field going, at least with the local regional therapies. I do have some disclosures. Now, I've been working in this therapy for over 10 years now. Personally, I've treated over 1,500 patients with this kind of therapy. What we're talking about here is radioembolization. I'll describe the rationale in a few minutes, but what we've tried to do as best as we can is to try to outline and at every point of development try to learn something. And so early on, when these therapies were developed, we need to figure out the safety and the basic concepts in terms of how to use this kind of therapy. And we've worked very, very hard to try to convert every learning point to some type of peer-reviewed data that at least we can be challenged on and share with the medical community and patients. There's probably more work that's been done in this therapy with HCC and colorectal cancer, but I think neuroendocrine is a very, very close third. There are two devices that are available, TheraSphere and CERSphere. I'm not going to spend too much time talking about them, but the concept is actually quite simple. Imagine here, this is a schematic, a very simple schematic of a liver. Do we have a pointer? We have a pointer, great. So I guess I'll speak on this side. We have a schematic here of a liver, and if you imagine that you inject these microspheres inside the liver, you sort of have them distributing all over relatively evenly. But because tumors are what we call hypervascular, which means they have more blood flow than the rest of the liver, what you have is a very intense concentration of these microspheres within this tumor. This is a very well-known rationale of many embolic therapies of injecting the liver. And what you are now left with is something called internal radiation. You've implanted a very hot, very radioactive source inside the liver tumor. So you take advantage of normal physiology, normal biology to treat these kinds of tumors. Now, the other thing that we need to point out is most of you, I'm sure, have done a lot of research on local regional therapies, hepatic-type therapies for the liver, but this is a major paradigm shift. This is not chemoembolization. This is not physically occluding the blood flow to tumors, which then can cause things called post-embolization syndrome and pain and discomfort. This is an angiogram. On the left here you see a liver angiogram of a patient being treated. And immediately after the infusion of the microspheres, you see the blood vessels, and there's absolutely no physical difference. And so this is a paradigm shift. You are not physically blocking the inflow of the tumors like you are with chemoembolization and bland embolization. So very different, and I'll talk about those differences a little bit later on tomorrow when we're talking about differences in various types of local regional therapies. This is radiation therapy, and so there is a half-life. It's a 2.5-day half-life, and when you look at what patients feel, it tends to be fatigue. Fatigue for 1 to 2 weeks, depending on how well you are prior to treatment. But essentially, that is the most common side effect that patients experience. Now, technique in this therapy is like surgery. It's like ablation. You have to have a lot of experience to do this well. And we have worked extremely hard with my colleague, Dr. Liu, who's here today, to really convert everything that we have learned into technical data and technical manuscripts. And so these are really sort of cookbook methods how to do this therapy. And I believe using these kinds of techniques, you can really converge your adverse event rate to well below 5%, if not 0. Now, what am I trying to show here? Well, again, this is a paradigm shift, and it is the delivery of a very intense radiation. And you've seen very interesting data shown here in terms of the Sutin data and other systemic chemotherapies. But what is really interesting with this therapy is that it gives you very intense partial response rates. And if something gives you very high partial response rate, then by definition, the progression-free survival should also be affected. This is a patient with a very large tumor in the liver here. 2 years later, near complete response after one single outpatient treatment of this therapy. No chemotherapy, no drugs, no hair loss, no side effect. It's a different paradigm. Here's another example, a very large 10-centimeter tumor. This happens to be a hepatoma that shrank in size, permitting the patient to have a transplantation. But for the surgeons, a large 18-centimeter tumor that was treated and now decreased in size to this, and the patient underwent resection, converting somebody that is not resectable to resectable. Very, very interesting concept. Unfortunately, I come to you with very few clinical trials that are ongoing with this. Certainly not the magnitude of clinical trials that you've heard from the other speakers. So let's go over a few of them. One of these is in Germany, where they are trying to compare a lot of these local regional therapies, the chemoembolization or the CERT, the radioembolization, surgery or ablation, and peptide receptor therapy, and as you heard before, primary outcome being progression-free survival, the best one to use at this point in this stage of development with this kind of therapy. But I can't agree more with the other speakers in terms of using quality of life. A lot of patients that we treat with this kind of therapy, their carcinoid syndromes completely disappear very, very quickly. What kind of inclusion criteria are going on in this study? This is sort of an observational study trying to enroll patients over 5 years. You want biopsy proven, but again, you want relatively tight inclusion criteria so that your conclusion in terms of what you find can be is relatively homogeneous and you can have reliable outcomes. There's another study from Vanderbilt that is also going on, a phase 2 25-patient study from Vanderbilt Cancer Center, also trying to capitalize on the fact that this is very intense radiation type therapy. The primary outcome here is tumor response. And I think that's obviously the easiest one to look at, because if you saw all of the other therapies are giving you very low response rate, which is they don't really shrink tumors. This kind of therapy shrinks tumors. So imagine combining a therapy that shrinks the tumor and then freezes it for a long time. You might be able to capitalize on a few therapies together. Inclusion criteria, essentially what other investigators have shown, although I would admit the concept of treating progressing patients is really something that you really need to look very hard in data, because some people show very long survivals, but I'm not sure these are truly progressing patients rather than the natural history of disease in these patients. RECIST criteria, that is, you must have lesions that are measurable, that you can actually assess response with. And in some cases with radioembolization, we do a diagnostic angiogram to make sure the microspheres will not go to the lungs, and so we do have a few parameters that we like to follow to make sure and to maximize patient safety. Now, we have 2 phase 2 protocols that we actually completed. We have yet to publish it, so I apologize. We've been swamped, but this is the data on 2 phase 2 studies. The first one is a 40-patient phase 2 study on the neuroendocrine using a low-bar or segmental approach. Again, notice that this is an outpatient therapy, so all patients go home the same day. There's no admission, there's no antibiotics in general, unless there are a few technical nuances. Notice here that fatigue is the most common side effect that these patients are going to get. It is similar to general radiation when patients experience fatigue. This is what we call a waterfall plot. A waterfall plot essentially shows the change in the tumor size after treatment. Now, all of these patients in general that we enroll have in fact progressing lesions. That is, they are getting larger on standard therapy. But if you look here, about 40 or 50%, if not more of these, in fact 60% or so, had a 50% reduction in tumor size. That is what we call a partial response. So very dramatic shrinkage of tumor size following this kind of treatment. This is a cytotoxic type therapy. Second phase 2 protocol that we just completed was standard 22-patient, standard Simon's 2-stage design that we completed. Again, endpoint, progression-free survival, as you've heard all of the other speakers talk about. Everybody had bilobar disease, everybody had multifocal disease, not resectable, not ablatable. Median age is about the same as we've had in all of our series, about 63 years of age, and most of these patients have relatively bulky disease, 25 to 50%. Usually patients get the right lobe followed by the left lobe treated. So most patients have 2 treatments to cover all of the disease, with, of course, some technical caveats in some patients that present with very unique presentation. If you look at the partial response rate, in our first study we had a 60% partial response rate. In this one we had 48% partial response rate. That is, reversal of progression of disease and shrinkage by at least 50%. If you look at the endpoint that everybody's talking about, progression-free survival, in this case, 9.4 months. Now, it is very difficult to do progression-free survival analyses when you are undergoing local regional therapy, because you may have a small lymph node that is just being observed, you have the right lobe that is being treated, but the left lobe that you haven't treated may slightly enlarge. How do you do tumor measurements when you haven't treated something? So it's a little bit different with local regional therapies. If you eliminate the 3 patients in this phase 2 study that had extrahepatic metastases, now we're up to 12 months progression-free survival in patients that are progressing, since that was one of the inclusion criteria for the protocol. Now, you heard a lot of talk about the elephant. I'm an interventional radiologist. I don't know where I would fit on that elephant in terms of the location, but certainly I think interventional radiology plays a big role in managing these patients. We perform ablation, we perform embolic type therapies. This is a manuscript by Dr. Coles talking about the role of interventional radiology. Now, tomorrow I'll be discussing in much more detail the actual outcomes in these patients treated with bland embolization, chemoembolization, and radioembolization. But what I would say is, having worked with this therapy for about 10 years now, these are the highest response rates that I see in any tumor that I treat. Partial response rate is well over 60% now in several series, including ours. So we have demonstrated the proof of concept, but unfortunately, we do not have the types of clinical trials that have been described by the previous speakers, although hopefully between today and tomorrow, we can entice people to collaborate and maybe combine the systemic agents and a local regional therapy like radioembolization. Thank you for your time.